tried to make this talk targeted towards trainees, and hopefully you'll find this interesting, particularly if you're preparing for taking call. I don't have any financial disclosures. A few goals and objectives. This is going to be a very CT focused talk. I will have a few plain films and MRIs to supplement that, focusing on the small bowel, looking at conditions that result in obstruction, ischemia, inflammation, and/or hemorrhage. Hopefully, this permits us to differentiate between surgical and non-surgical cases and help guide management for our referring clinicians. So I'll start with a little bit of an unusual case, and this is a case that begins with a plain film. That's not really a common thing in our practice. These days, most people go right to CT. But at any rate, this patient has dilated small bowel. You can see small bowel loops in the left upper quadrant are more than 3 centimeters in size. There are differential gas fluid levels in multiple areas, and this nice string of pearls sign all radiographic signs of small bowel obstruction. That was confirmed on this CT. The CT demonstrated a smooth transition point in the central abdomen without an underlying hernia or mass. And so, by pure exclusion, this is a case of an adhesive obstruction. Adhesions are, of course, the most common cause of small bowel obstruction. Less commonly, hernias, tumors, and inflammatory strictures, such as from Crohn's disease, among others. This example on the right side of the screen is an even more rare example in which we can actually see the cause for the obstruction on the radiograph, in that we see gas within the pelvis beyond where we would expect the peritoneal cavity to end, projecting over the obturator foramen, and the CT confirmed this obstructing left inguinal hernia. Contrast that with this case, another patient with small bowel obstruction, dilated small bowel loops, transition point in the right lower quadrant where we see some small bowel feces here. We'll talk about that sign later and what it may or may not mean. But in the transition point, we see bowel extending into the groin. You can see there's deformity of the right common femoral vein. This obstruction is passing lateral to the pubic tubercle here, and this is a femoral hernia. These, of course, are more common in women, but less than 10% of all groin hernias. They are taught to be more commonly associated with incarceration or strangulation. It's important to know that hernias, not just femoral hernias, but all abdominal wall hernias, tend to be intermittent. They tend to develop adhesions at the site of the hernia neck, and sometimes that's the underlying cause for the obstruction. So, yes, the surgeon will go in and repair a hernia, but they also have to do a lysis of adhesions often to eliminate the underlying obstruction completely. And again, if you're debating between an inguinal and a femoral hernia as an underlying cause for small bowel obstruction, based on the odds, it's probably an inguinal hernia. But if you see sort of a funnel-shaped neck, if you see it touching or deforming the common femoral vein, if you see it traversing lateral to the pubic tubercle, those are all signs that may allow you to suggest a femoral hernia rather than an inguinal one. Here's an even less common abdominal wall or pelvic hernia causing small bowel obstruction. Again, dilated small bowel loops, a very subtle transition point in the pelvis. I think it's easy to sort of go past this if you're working overnight or on a busy shift. But notice this asymmetry in the pelvic musculature on the right compared to the left. So this is a hernia occurring between the pectineus and the obturator externus muscles. This is an obturator hernia causing this woman's small bowel obstruction. And of course, I could spend the entire talk talking about various types of abdominal wall or abdominal hernias that can cause small bowel obstruction. This is a patient with a massive diaphragmatic hernia containing not only obstructed but ischemic small bowel. This is a more subtle small bowel obstruction occurring at a laparoscopy port site. Very small sort of knuckle of small bowel coming out here, but enough to probably cause underlying adhesions and also obstruction there. And of course, very common umbilical hernia, again, causing obstruction. This one was strangulated with underlying developing ischemia with all this edema within the small bowel mesentery and ascites. So we talked a lot about abdominal wall hernias and causing obstruction. This slide I show to just demonstrate that we focus on things like internal hernias, and I'll talk more about that in just a moment. We focus on things that tend to cause ischemia. It's important for us as radiologists to remember that one of the most important causes of ischemia and small bowel obstruction is overdistension. And that makes sense. When someone has small bowel intraluminal pressure that is higher than the pressure in the capillaries, you can't perfuse the mucosa and ischemia results. This is a patient who had a chronic debilitation. She presented over and over again with a small bowel ileus. She actually didn't have a mechanical obstruction, although she did have some twisting in her small bowel mesentery. They decided to go ahead and treat her conservatively, as they always did. And unfortunately, she came back later with this scan here, which demonstrates complete loss of the normal bowel wall throughout the entire small bowel. We're basically unable to separate intraperitoneal fluid from bowel wall, from intraluminal fluid. Her entire small bowel became ischemic, and entirely because of overdistension. And so this is why we place nasogastric tubes, right? We don't want patients to get so distended that they get ischemia as a result. As an aside, this patient is also developing abdominal compartment syndrome. Her inferior vena cava is flattened. You can see small caliber of the pelvic vessels here because the pressure inside the peritoneal cavity is in fact so high that other organs are getting ischemic as well. This is a case that hopefully we catch earlier than that last one. This is a patient who has a small bowel obstruction. You can see dilated bowel loops in the left mid-abdomen, but also notice this radial distribution of bowel loops and the differential enhancement. Look at this normal enhancement here in this small bowel loop anterior to the psoas muscle, whereas these loops here are hypoenhancing. There's mesenteric edema, and this balloons on a string or radially distributed bowel should make us think about the possibility of a closed loop obstruction. And the main situations where you get ischemia complicating small bowel obstruction are severe distension, as I mentioned, and closed loop obstruction as well. Occasionally, you can see ischemia from things like volvulus or intussusception. But we like to think about closed loop obstruction specifically because it's really on the radiologist to identify these patients. This is an important subset of small bowel obstruction because they cannot be decompressed by vomiting or by nasogastric tube suction. And that's because usually the inlet and outlet of the obstruction are occurring at or very near to the same point. One bit of caution I would mention is that when patients have been vomiting or have had a nasogastric tube, that they may decompress proximally and make you think about closed loop obstruction. But again, usually closed loop obstruction happens where the inlet and outlet are obstructed at the same point. So if you have a bowel obstruction with transition point in the right lower quadrant, and you happen to have some decompressed jejunum in the left upper quadrant, usually that's not a closed loop obstruction. But if you see this C or U-shaped bowel loop that's obstructed, or again, when a longer segment is obstructed, this radially distributed clumping of bowel loops, you should think about the possibility of a closed loop obstruction and risk for ischemia. Here are a few patients who have long segment closed loop obstructions. Again, some people think this looks like a bag of bowel, where the bowel is sort of so clustered that it almost looks contained. This looks sort of like a smiley face. I'm not really sure why that happened, but suffice it to say the patient probably wasn't very happy about this severe small bowel distension and mesenteric edema. Again, fanning radially distributed loops of small bowel in the left mid-abdomen, lots of mesenteric edema. Similar situation here in the pelvis. Again, you can almost sense that sort of tethering of these obstructed bowel loops at one point in space. I mention to my residents all the time that when the bowel is abnormal, I don't care if it's obstructed, thickened, thinned, something just doesn't look right. Go back and look at your mesentery, particularly the mesenteric vessels. This is a patient who has a Billroth 2 anatomy. Came in with this clear small bowel obstruction, multiple dilated small bowel loops, most of which are not enhancing very well. Look at the mesentery here, very twisted, abrupt cut up of the superior mesenteric artery. I can't even really find much of a superior mesenteric vein because there's not much blood return into the portal venous system. This is a volvulus. And honestly, this is a case where the anatomy of this internal hernia, which is what it was, isn't actually that clinically relevant. This person has a high-grade small bowel obstruction with volvulus, with vascular compromise and occlusion. This is a trip to the operating suite, and this happens to be a transmesocolic internal hernia, but that detail is less important than identifying the vascular compromise. These are the patients that truly scare me. This is a patient who almost has a normal CT. She has a Roux-en-Y gastric bypass. The only clue that she has an internal hernia here is the fact that her transverse colon is interposed between her small bowel mesentery and the retroperitoneum. That's really not a normal relationship. A normal relationship should be that the transverse colon is usually in front of the small bowel mesentery. Now, if you have an anticolic Roux-en-Y gastric bypass, the Roux limb can go in front of the transverse colon. But this is small bowel and mesentery coming from above through a hole in the transverse mesocolon and extending down. I would also clarify that this is not bowel that's folding up in front of the transverse colon from below. So clearly an abnormal anatomic relationship, but no small bowel obstruction, no mesenteric edema or no ischemia here. This is a non-obstructed internal hernia. A laparoscopy confirmed it. And these are the patients we try to catch early before they get a closed loop obstruction. One important sign, in addition to abnormal anatomic relationships of the bowel, is the shifting anastomosis sign. This is a patient who presented with abdominal pain. You can see that he has some edematous small bowel mesentery with clumped bowel loops on one side of the abdomen. And then a really helpful feature is the fact that on this previous post-op leak check, his jejunal anastomosis is in the left mid-abdomen rather than in the central abdomen, as is the case here. And this is someone who has an internal hernia, not causing a mechanical bowel obstruction at this point. There's really not that much dilated small bowel. There is mesenteric edema, abnormal anatomic relationship, and this is someone who went to surgery right after this. Your mesentery is definitely your friend when you're looking for an internal hernia, not only in terms of edema, in terms of abnormal course, but also looking for mesenteric twists. This is a very sensitive, but not at so specific sign for internal hernia, but is one you should really look out for, especially in patients who have a postoperative anatomy that predisposes them to an internal hernia like this one here. So when you're trying to find the best performance for CT signs predictive of internal hernias, mesenteric swirl is the most sensitive. Again, we're looking for clustered bowel loops in an abnormal location. We're looking for abnormal bowel or mesentery passing between the aorta and the superior mesenteric artery, especially proximally. The transverse duodenum should be the only loop of bowel in that space. And so if you see bowel and mesentery crossing midline between the root of the mesentery and the retroperitoneum, you should take a close look at that, especially in patients at risk. Mesenteric edema, so-called mushroom sign, which is sort of a constriction of the internal hernia neck, shifting anastomosis like we saw a couple examples ago. And remember that patients may or may not have a closed loop obstruction or volvulus. These are the types of patients that we're trying to prevent. This is another patient with an internal hernia, swirled small bowel mesentery, clearly hypoenhancing small bowel with extensive mesenteric edema. This patient had nearly half of her small bowel necrotic at surgery. And so these are patients that we try to catch earlier when they present at a proximal time in their disease course. So here's another patient with small bowel obstruction. This patient's a little bit different than the ones I've showed though, because the bowel wall looks quite a bit different. This bowel wall is higher in attenuation than skeletal muscle. There's asymmetric edema towards the mesentery, and there are multiple areas of bowel wall narrowing and stricturing. This, of course, is a patient with acute on chronic Crohn's disease as the cause for their presentation. And one of the main topics, or one of the major topics I get consulted on, and quite honestly, I consult other people for, is that of small bowel thickening. I think this is a very tough topic. It's a topic that first requires you to assess whether or not the bowel is distended, because sometimes the bowel, especially the jejunum, is peristaltic and collapsed rather than being actually thickened. But once you've determined that it is, you should ask yourself, is this focal or diffuse bowel wall thickening? And what color, quite simply, is the bowel wall? Is the attenuation more so-called white attenuation, where the bowel is higher in attenuation than skeletal muscle? Is it more gray or iso attenuating to muscle? Is it water attenuation or sort of water halo? Is there submucosal fat or submucosal gas? When we think about high attenuation bowel wall thickening or white attenuation, think about Crohn's disease. It tends to be hyper enhancing relative to skeletal muscle. And we think about that in particular when we see associated inflammation towards the mesentery that's nodular and asymmetric. We think about it when we see things like penetrating disease with fistulae and abscesses. And we think about it in people who are at risk for it, often in the young. Other things to keep on your differential diagnosis in high attenuation or white small bowel wall thickening include tuberculosis, which is sort of can look a little bit like Crohn's disease, hypoperfusion complex or shock bowel. And then if you're doing a non-contrast CT, acute hemorrhage is also a possible cause for high attenuation small bowel wall thickening. Here's a patient with hypoperfusion complex. Notice the hyper enhancing adrenal glands, the flattened inferior vena cava, and the marked increased attenuation of the small bowel that's enhancing more than muscle. Again, so-called white attenuation of spastic reflex ileus in this patient with hypoperfusion complex. This can be a little confusing because the same condition, depending upon where you're at in the patient's resuscitation, can also look like this, which is more edema within the small and large bowel. You can tell that this is probably third spacing though, because of the periportal and body wall edema that's accompanying it. You should look for ancillary signs, namely hyperenhancing adrenal glands. You can have sort of bizarre areas of hyper or hypo enhancement of the liver and spleen. Remember that patients in cardiogenic shock may or may not have a flattened IVC, like in this case here. And it's a good thing to remember, especially in trauma patients. This is a patient who has high attenuation bowel wall thickening in the proximal jejunum, again, higher than the skeletal muscle. This is a non-contrast CT, and this patient was anticoagulated. Notice this patient also has more bowel wall thickening in the pelvis, and this was spontaneous hemorrhage due to a supertherapeutic INR. Just to hammer home the importance of small bowel obstruction and ischemia, this is a patient who has a gasless small bowel on this radiograph. Again, radially distributed obstructed small bowel loops in the right mid-abdomen with high attenuation bowel wall thickening and high attenuation edema within the mesentery. This is actually mural and mesenteric hemorrhage from ischemia complicating a closed loop obstruction. Remember that hemorrhage within the bowel wall is one of the most specific signs for ischemia complicating small bowel obstruction. Here's another patient who has small bowel wall thickening, but in contrast to some of those recent cases, this patient has more low attenuation within the small bowel wall, lots of mesenteric edema, there's ascites, there's body wall edema, pleural effusion. This patient is third spacing because he has cirrhosis and liver failure. And so keep in mind third spacing when you see low attenuation, small bowel wall thickening, especially when it's diffuse with other signs of volume overload. When it comes to the water halo sign or simply water attenuation in the submucosa, think about again third spacing. Infection can have this appearance, although it's uncommon for us to get a microbiological confirmation of it. Really need an inciting history to invoke infection of the small bowel, but it's almost always one that we can appropriately throw in there. And then ischemia. Ischemia is a little bit confusing because it can have multiple appearances. Ischemia, when it's venous or when there's reperfusion type phenomenon, can look like this targetoid look. This happens to be a patient with small bowel obstruction with sort of a reperfusion type injury to the sort of penumbra of the obstruction here. Here's a similar looking patient with very sort of stratified small bowel. Again, water attenuation in the submucosa, not obstructed here. Mesenteric vessels look open, sort of an unsatisfying case of small bowel wall thickening. I think it's very easy and tempting to say this could be inflammatory, infectious, or ischemic. In this case, a glance at the patient's medication history might draw you to think about something like angioedema. In that case, it was a patient on an ACE inhibitor, and really that is a required observation to make this or suggest this diagnosis is looking at the patient's chart. It doesn't matter when they've started the ACE inhibitor. It doesn't have to be a recently started medication, but it basically looks like this. It looks like someone who has submucosal edema, but without a venous occlusion, without an underlying obvious cause like third spacing or infection. Things like pneumatosis or perforation are very atypical. But truth be told, we don't get pathologic confirmation in most of these patients. We say this could be related to their ACE inhibitor. They stop the therapy, they come back, the bowel wall thickening has resolved, and we sort of say, oh, how smart are we? We figured this out. But it's a good one to keep in mind. Drug-induced enteritis in general, I think, just requires an awareness that certain medications can cause enteritis. So that requires looking at the patient's treatment history and saying, hey, I see this pretty mild but real jejunal wall thickening. This could be inflammatory, infectious, or ischemic. That's very easy to say, except really doesn't look like infection. It doesn't look like ischemia. But noticing that this patient is on several targeted agents that might cause an enteritis is helpful. And so anything that ends in ib or ab probably should be on your radar for causing these kinds of things. And if you're working at a cancer center in particular, it's good to look at these medication and treatment histories and to suggest it when appropriate, like in this patient here. Here's another patient whose history would really help out to nail down what's causing this small bowel wall thickening. I think the appearance itself is suggestive, though. You have mucosal hyperenhancement and some relatively mild submucosal edema involving the distal small bowel. This patient also happens to have diarrhea. You can see liquid content in the colon with some colonic wall thickening. I think on a good day, we might suggest that this is graft versus host disease, which is what this happens to be. But you have an increased odds of getting that diagnosis if you look at the patient's history and realize that they're neutropenic, that they just got a bone marrow transplant, that they're the exact patient population who might get this, and that helps you be a little bit more specific. Here's another patient with water attenuation in the submucosa. There's mesenteric edema. Again, very easy to say, is this angioedema from an ACE inhibitor? Is this ischemia? Is this somebody who had a recent bowel obstruction that's resolved? I think, though, if you carefully notice the arrow sign here pointing to the superior mesenteric vein, you'll notice that the blood within the superior mesenteric vein is higher attenuation than that of the aorta. And so clotted blood attenuates more than unclotted blood. We are suspicious for a venous occlusion here, and that was confirmed on this MRI. That nicely demonstrates targetoid stratification of the small bowel wall, small bowel edema, and mesenteric edema with ascites. This is venous ischemia from SMV occlusion. A good thing to keep in mind when you see a thickened small bowel. Contrast that with this case. This is a patient who has some infarcts in the right kidney, infarcts in the spleen, and gray attenuation of the small bowel. This small bowel is attenuating less than the muscle. You also can't differentiate the fluid in the small bowel from the wall. This look should really strike you as abnormal, but I find these cases are the easiest ones to overlook because we say, oh, there's fluid-filled small bowel, it's not really thickened, the mesentery doesn't look particularly edematous, this is just an ileus. I think very easy to write that off, but especially in somebody who clearly has a possible embolic source, go back and look at the vessels. The SMA is occluded here, and all of this dilated small bowel with wall thinning and gray attenuation is not only ischemic but necrotic. When it comes to gray attenuation, we're talking about wall attenuation similar to the skeletal muscle. It doesn't look stratified. Chronic Crohn's disease with fibrotic strictures can look like this. Ischemia, especially arterially based ischemia, can do it, as can tumor. Here is a patient with Crohn's disease with several fibrotic strictures that are causing chronic obstruction. Again, notice that the attenuation of the wall is less than or equal to the skeletal muscle. But also notice this stricture here looks a little bit higher in attenuation. So this is a patient with multiple chronic fibrotic Crohn's strictures, but also is complicated by adenocarcinoma that looks a little bit different than these other Crohn's strictures. Depending upon the primary tumor, these may look different in terms of enhancement, but they tend to be similar to the muscle. This is a primary small bowel cancer, granulocytic sarcoma or extramedullary AML, peritoneal metastases from ovarian cancer. Obviously, there's a many-fold collection of causes. This is a case of urothelial cancer, and this is carcinoid tumor here. When it comes to malignant small bowel obstruction, metastases are much more common than primary tumors. They can be hematogenic, classically melanoma can give you an exoenteric small bowel mass and occasionally obstruction, and then common things being common, lung and breast as well. Peritoneal carcinomatosis, we think of commonly in GYN primaries like ovarian cancer, but also from GI primaries that have spread to the peritoneal cavity. And of course, extrinsic compression can occur, which is more common than intussusception, which tends to happen with more mucosal-based processes. Here is a patient who has a small bowel obstruction. The transition point is in the right lower quadrant where we see this sort of matted gray attenuation look. We thought that this was going to be malignancy in this 80-year-old man. They took the patient to surgery because there was no other evidence of metastatic disease. And this actually turned out to be sort of a smoldering perforated appendicitis that resulted in sort of a phlegmonous collection and a small bowel stricture. I think hard to make that diagnosis at this point in the game because things are so distorted. But a good thing to keep in mind, chronic appendicitis or complex appendicitis can cause small bowel obstruction. I'm also showing this case because of the contents of the small bowel, which demonstrates small bowel feces. It's mostly useful for finding the transition point. People have debated in the literature the meaning of small bowel feces or pseudofeces. Some people think that it's prognostically positive, that the body is trying to compensate for the small bowel obstruction. Other people think that it's a negative prognostic indicator. So with that sort of disagreement, we know that it's probably most meaningful in determining where the transition point is. However, it's not specific for obstruction. We'll look at some similar looking cases here. This is a patient who has mottled material that sort of looks like small bowel feces. It's near the transition point of the obstruction. There's surrounding mesenteric edema, but there's a similar looking mass in the stomach with mottled material, sort of clump of stuff in the gastric fundus. And this is a patient who had been eating her own hair. I'm sorry if you're eating dinner right now while watching this lecture, but this is what it looked like when they took the trichobezoar out. The other variant of Bezoars that we see that honestly I think is a lot more difficult to diagnose unless you're thinking about it is the so-called phytobezoar or bezoar from plants. Classically, things like persimmons can cause this. This patient was actually eating uncooked rice and kept presenting to the emergency department with small bowel obstruction. We kept saying, oh, there's this pseudofeces here, but really this mottled material here and similar looking stuff in the stomach finally got us to clue in that this might be a plant-based bezoar, and this patient was treated conservatively. This is a similar look too. This patient has mottled material within the small bowel, uh, sort of at the side of the small bowel obstruction. But the clue here is this patient's fatty replaced pancreas. So rather than having a mechanical obstruction from something like an adhesion or an internal hernia, this patient has an intrinsic obstruction due to the bowel contents. This is meconium ileus equivalent or distal intestinal obstruction syndrome. Kind of a similar look here of someone with a small bowel obstruction, lots of mottled material in the small and large bowel. This person has a normal pancreas, though, does not have adhesive disease, really doesn't have an underlying cause for these findings, except for their medication history. Again, look at your patient's charts, look at their histories, and this person's chronic opioid use is the cause for this ileus of the small and large bowel with all of this pseudofeces everywhere. Another case where the bowel contents are the clue to this classic diagnosis of a patient with pneumobilia, a contracted gallbladder, and a small bowel obstruction with a rounded calcified object at the transition point. This, of course, is the so-called gallstone ileus from a biliary enteric fistula, classically between the gallbladder and the duodenal bulb. Small bowel contents, again, they include the obstruction here. Hopefully not too much of a diagnostic dilemma. In this case, someone who has a transition point with mesenteric fat, vessels, and soft tissue in the bowel lumen. This is a patient with metastatic leiomyosarcoma. You can see the metastases in the liver and a long segment, a small bowel intussusception as the cause for their presentation. So remember to look at the contents of your small bowel. We talked about looking at the bowel distribution. We talked about looking at the bowel wall, but you should also look at the lumen of the small bowel to look for pseudofeces, especially in identifying that transition point, to look for things like bezoars, occasionally intussusception. In adults, you should think about the possibility of malignancy, except for transient intussusceptions that commonly happen in the jejunum and are usually not accompanied by obstruction, and then gallstone ileus as well. Another example of the bowel contents as the underlying clue to the cause of this patient's presentation. In this case, an MRI was performed because the patient is pregnant. You can see her fetus sort of waving at us here. Cystic lesion in the terminal ileum. In addition to the cystic lesion, there's a bowel within bowel type appearance. And this is an intussusception that occurred because of a Meckel's diverticulum that was diagnosed surgically. Meckel's diverticula, I found more commonly present in adults like this, with sort of a focal outpouching, a contour abnormality that has a blind end, sometimes with surrounding inflammation, like in this case here, that clinically they suspected appendicitis. Here's the normal appendix here, but there's this thing coming off of the terminal ileum that doesn't look like it should be there. And this is another case of Meckel's diverticulitis. Another example here, focal contour abnormality, outpouching along the terminal ileum with a small perforation in this case. This is a perforated Meckel's diverticulitis. A counterexample here of someone with a contour abnormality of the small bowel with a focal outpouching. In this case, though, there's soft tissue surrounding it, very thickened eccentric mass involving the second portion of the duodenum. The mass contains bubbles of gas, and so this is an exoenteric mass off the proximal duodenum. This is a gastrointestinal stromal tumor. Again, tumors are a good thing to keep in mind, not just in terms of having a sort of gray attenuation, or in this case, probably a little bit higher than gray attenuation, but also in terms of causing an abnormal small bowel contour. Contrast that last case with this one, very similar anatomic location, but a very different look. There is a focal outpouching from the proximal duodenum. This outpouching doesn't have much of a thickened wall, but there's quite a bit of surrounding fat stranding and fluid, and this has a gas fluid level within it. This is a deeply penetrating but not yet perforated duodenal bulb ulcer causing this patient's presentation. When it comes to peptic ulcer disease, it's important for us to remember that the duodenum is a more common site of disease than gastric ulcers. Most of them occur in the duodenal bulb. Most of them are solitary and have low malignant potential, and usually these occur due to increased peptic acid secretion, like from H. pylori infection. These can be quite subtle. This was a case of a very small outpouching from the junction of D1 and D2, or the first and second portions of the duodenum. The clue here is the loss of fat plane between the descending duodenum and the pancreatic head. Look at your reformats. Sometimes these are in the plane of scanning and harder to see. I think it's much easier to appreciate this focal outpouching with surrounding inflammation on the coronal image here, and this is another peptic ulcer. One subtype of ulcers of the bowel that get missed more commonly, in my opinion, are these. These are marginal ulcers. Marginal ulcers happen classically at a gastrojejunal anastomosis, usually right on the jejunal side. And in this case, this outpouching is causing a reactive sort of hyperemia within the liver. There's probably a little adjacent thrombophlebitis here. And this is just a very deeply penetrating ulcer at the gastrojejunal anastomosis. So marginal ulcers you should think about in patients who've had a Billroth 2 or Roux-en-Y gastric bypass. These tend to occur a few years after surgery. They can grow quite large, and because the liver and other structures are surrounding them, sometimes they get misdiagnosed as a primary abnormality of, in this case, say the liver, rather than being a primary enteric process. So, like so many things in life, knowing what a marginal ulcer is and recognizing it on a CT scan requires just having it in the presence of mind that it exists and can happen. Well, here's another case of someone with ulcers of the proximal small bowel. In this case, though, rather than being from the duodenal bulb like most occur, this patient has ulcers well into the transverse duodenum. She also has hyper-enhancing rugal folds. She has some esophagitis and a very sneaky hyper-enhancing nodule here near the pancreatic head. This is a patient with a gastronoma and Zollinger-Ellison syndrome. This happens because of increased peptic acid secretion that causes GI mucosal ulceration. The CT findings include gastritis and esophagitis. Look for multiple duodenal ulcers, especially when you see them distal to the bulb. That's really not a typical distribution of duodenal ulcers. And when you start seeing multiple distal ulcers, think about either Zollinger-Ellison syndrome, like in this case here, or potentially Crohn's disease involving the upper GI tract. It can be quite hard for us sometimes to differentiate these hyper-enhancing gastrinomas from surrounding lymph nodes. And so something like a dotatate PET CT might be helpful to identify a potential primary if they have elevated gastrin levels. Here's another patient with an outpouching of the small bowel. In this case, it's a little bit distal. It doesn't really look like an ulcer, right? We don't see disruption of the mucosal enhancement, but rather there's this sort of boot or sock-like outpouching. It's a classic location for a duodenal diverticulum, and there's surrounding inflammation. This is a case of duodenal diverticulitis. Not very common, but duodenal diverticula are, of course, quite common. And so it makes sense that at times we get complications. Here is a patient who presented with suspected appendicitis. They had this extraliminal gas and inflammation in the right lower quadrant. It was really quite hard for us to determine what was causing this. We thought the appendix was over here and separate from this extraluminal gas. And thankfully, this patient had a prior study from 2 months ago that demonstrated diverticula within the distal small bowel. And this is sort of a true diverticulum, or excuse me, a more typical diverticulum of the terminal ileum, similar to colonic diverticulosis, in this case, perforated into the small bowel mesentery. Just to round out our differential diagnosis for contour abnormalities or sort of focal outpouchings or mass-like enlargement of the small bowel, remember chronic perforation. This is a case we all thought was going to be a tumor. I said this is probably a GIST or melanoma metastasis or lymphoma. This was actually the first presentation of Crohn's disease for this patient with a large intramural phlegmon that had organized over time. So when you see a contour abnormality on an emergency CT, patient presenting with abdominal pain, think about peptic ulcer disease, especially in the duodenal bulb. Remember post-bulbar ulcers to think about Crohn's disease or Zollinger-Ellison syndrome. Think about Meckel's diverticula and more classic diverticula as well. Tumors, especially metastases, gastrointestinal stromal tumor, or if they're forming a stricture, potentially a primary adenocarcinoma, and occasionally chronic perforation can cause this presentation as well. Another patient with a contour abnormality of the small bowel, multiple outpouchings here. In this case, I'm not showing you that to demonstrate the wall so much as I am the contents of the small bowel. Let's take a step back and look at this pre-contrast scan, which demonstrates distended bowel with high attenuating material that's higher in attenuation than the muscle. After administration of contrast, we see brisk extravasation into the lumen that spreads out over time and fills these diverticula. So we're very confident we have bleeding small bowel diverticulosis here. I think it's very helpful to notice that, number one, we did a pre-contrast scan. So we aren't going to be fooled by things like calcium or pill fragments within the lumen. Number two, it helps us identify this freshly clotted blood within the small bowel, distending it. Most people with brisk bleeding into their small bowel have sort of a cathartic type phenomenon. So it doesn't make sense to have completely normal looking small bowel with a small focus of active extravasation. This person is bleeding on our CT scanner because they've been bleeding before they got on the CT scanner too. We're not just capturing it beginning. And so keep in mind that not just in the small bowel, but in general, if you're going to diagnose active bleeding anywhere in the body, that the active extravasation should be surrounded by non-opacified hematoma. This patient was embolized. Now that was a pretty obvious case of bleeding. The ones that really scare me are the intermittent bleeders with sort of mysterious causes. This was a patient with a previous open abdominal aortic aneurysm repair who was presenting with intermittent episodes of hematemesis. In this case, the important finding is near the site of repair, there's a focal outpouching of the aorta into the transverse duodenum. We don't see active extravasation. We really don't see much blood in the duodenal lumen, but this was an aortoenteric fistula, and unfortunately, this is sometimes all you get. Most often, we see this after open repair of an abdominal aortic aneurysm. Clinically, they can present with a mild bleed 1 or 2 times, and then eventually they present with exsanguinating hemorrhage. You really don't need to see active extravasation. That's rare. There, you can see disruption of the aortic wall. You can see loss of fat plane between the aorta and adjacent bowel, classically the transverse duodenum. Pay attention to how recently this surgery was done. If they had surgery 2 weeks ago, you can still see gas in the aneurysm sac and surrounding inflammation. If the surgery was 3 years ago, you really shouldn't be seeing extraluminal gas, fluid, and inflammation surrounding the aorta. Occasionally, you can see pseudoaneurysm formation, which is what was sort of happening here. And really, this can happen with any graft material. When you're trying to diagnose a fistula between an artery and something else, whether you're talking about the bowel, the ureter, the esophagus, what have you, usually there's something implanted or sort of a risk for infection or erosion. think about it in particular in patients who have had radiation to the affected area. Radiation, one of my gastroenterologists sort of affectionately refers to radiation as the quote fistula machine. So radiation can definitely predispose you to vascular fistulae. And the clinical history again, this patient presented with repeated episodes of bacteremia. They have a graft into their SMA. There's extraluminal fluid and bubbles of gas far removed from the perioperative period. This is an infected graft with a fistula to the bowel. Now, this patient also has a problem with their bowel, but in this case, it's not due to a fistula from the artery, but rather they were in a motor vehicle collision. They have hemoperitoneum, and they have this triangular collection of blood in the mesentery with some adjacent, slightly hypo-enhancing small bowel loops. This is a blunt abdominal injury due to a motor vehicle collision, and this patient underwent a bowel resection. It's really important to observe hemoperitoneum, number one, but also to account for why it's there. If someone has hemoperitoneum and they don't have a solid organ injury, your mind should immediately go to, is there a bowel or mesenteric injury that I am missing here? In this case, thankfully, it was quite apparent because of the active bleeding within the small bowel mesentery. This is a case of someone with a mesenteric injury. A lot of people spend time differentiating between active extravasation and pseudoaneurysms in someone who's bleeding. To me, especially when it's in the mesentery, it really doesn't matter. Both of them mean that there's a hole within the small bowel, a hole within the small bowel artery, rather. In this case, there's a pseudoaneurysm, but also active bleeding here. You can see the active bleeding is spreading out, whereas the pseudoaneurysm doesn't. Now, a pseudoaneurysm is probably a little bit more stable than active extravasation, but we've all seen pseudoaneurysms rupture and become an active extravasation. And I've also seen active extravasation that walls off and becomes a pseudoaneurysm. So I sort of think of them as a continuum, but it's important for us to recognize these in blunt trauma and realize that this is a surgical emergency. This is not a, observe and see if this clots off and takes care of itself. Here's a more subtle case of someone who has a blunt abdominal injury, large hematoma, in this case in the transverse mesocolon. Just a reminder that the colon has a mesentery too, and we often think about small bowel mesenteric injuries, not necessarily thinking about those anatomic spaces, but obviously equally important. This patient was not in a motor vehicle collision, but rather was stabbed in the right lower quadrant. You can see the stab wound started here in the subcutaneous tissues with some active bleeding, and there's subjacent thickening within the cecum and the terminal ileum. There's hemoperitoneum in the lower abdomen and a focus of intraperitoneal active bleeding. Clearly a patient who needs to be explored, and this was a knife wound causing a small bowel injury. Unfortunately, most patients don't come in like this, though. This is a patient who had a psychiatric history and was predisposed to stabbing herself repeatedly. And in this case, we know exactly how deep the knife went because the knife is still in the patient. What's harder is when someone is stabbed and you don't know how deep the injury goes. This is one case like that where the patient was stabbed in the epigastrum. You can see that there is a small amount of hemoperitoneum, and there's blood within the colon here, or at least posterior to it in the colonic mesentery. And so just like the small bowel mesenteric injuries, it's important to pay attention to distribution of blood. Spaces matter. And remember that sometimes stab wounds in particular can be quite subtle. In contrast, this patient clearly must have a bowel injury. They have a gunshot wound that went through the left iliac wing. The bullet landed in the right upper quadrant. There's hemoperitoneum. And if you trace a line between these 2 points in space, there's an awful lot of small bowel in the way. In this case, clearly thickened adjacent mesenteric blood. And just on the basis of the trajectory of this injury, we should be worried about small bowel injury. This one's easy to overlook. This patient was shot through the right upper quadrant of the abdomen. You can see an extensive liver laceration, laceration going through the hilum. There's a gallbladder injury. There's an inferior vena cava injury. Very, very easy in trauma patients to overlook one of the injuries when you see so many of them. Unfortunately, they can have as many injuries as they want to, especially in blunt trauma. In this case, it's important to remember that the transverse duodenum and the descending duodenum are in harm's way, and this was a bowel injury. Just a point that tracing the path of a penetrating trauma is really important to finding these bowel injuries because they can be quite subtle. So I'm going to leave some time here at the end for questions. We kind of had a whirlwind tour of small bowel emergencies talking about obstruction. Remember that we need to identify patients who are at risk for ischemia, especially patients with closed loop obstruction and internal hernias. We talked about bowel wall thickening and trying to create an approach to that using the length of small bowel involved and the attenuation or the color of the bowel wall, and um, trying to approach it from that standpoint. Look at your intraluminal contents, not just small bowel pseudofeces to find the point of obstruction, but also things like intussusception can be obviously quite helpful in identifying the underlying cause. We talked about ulcers, diverticula, and tumors, among others, causing contour abnormalities. We talked a little bit about bleeding and perforation, including in trauma. And just as an overarching point, I think, especially when you're looking at things like bowel wall thickening, to avoid looking less smart than you are, and I'm sure all of you are quite smart, look into your patient history, look at your prior studies, because that's going to take you from perhaps getting an impression or an opinion that's not as precise and really altering clinical management potentially. At that, I'll stop, answer any questions we may have, and thanks